Hello everyone, welcome to our presentation on Charcot-Marie-Tooth disease, also known as CMT. My name is Sindhu Ramchandran. I am an assistant professor of neurology at the University of Michigan, and I direct the Muscular Dystrophy Clinic and the CMT Clinic at the university. The goals of the talk are to define what neuropathy means, define CMT and how it affects people, provide an overview of the mutations that cause CMT, and finally, an overview of our clinic and research being conducted at the university and the Inherited Neuropathy Consortium. Let's start with defining neuropathy. Your nervous system consists of your brain, your spinal cord, your peripheral nerves, and your muscles. Your nerves are essentially wires that connect your spinal cord to the muscles. When we say neuropathy, we therefore mean nerve damage. Your nerves look very similar to electrical wires. There is an outside insulation called myelin in the nerves, and inside there are several cables called axons. The axons conduct the electrical signal from the brain to the muscle, and the myelin prevents the electrical signal from leaking. Nerves can be damaged in one of two ways. Either the axon can be affected, or the myelin. When there are fewer cables to carry the signal down from the wire from the brain to the muscle, that type of nerve damage is called axonal neuropathy. When the myelin is affected, the effect is like having a leaky insulation, and the signals can't reach the muscle quickly enough, and this is called demyelinating neuropathy. If the problem is with the nerve, then why does the muscle get weak? To understand this, take a look at this garden analogy. Imagine the hose as your nerve and the garden as your muscle. When the electrical signal is traveling well, the garden grows well and is healthy. In neuropathy, the signal is like a leaky hose, so less water can get through. Now your body can repair nerves and attempts to heal the leaks on its own. But if we can't fix what's causing the leaks in the first place, then new leaks will continue to develop. So for example, if you have neuropathy due to diabetes, if the blood sugar stays high, your body cannot repair the nerves and new nerve damage occurs. In a genetic neuropathy such as CMT, the coding instructions for the new nerves are faulty, so the new wires still have leaks. Over time, this leads to less signal getting through, and eventually the muscle gets weak. In the US, the most common cause of neuropathy is diabetes. Patients can have diabetes and CMT, both causing neuropathy. Other causes of neuropathy include chemotherapy, infections such as leprosy, which happens to be one of the most common causes of neuropathy worldwide, autoimmune diseases and medications, etc. Another very common cause of neuropathy is CMT. We determine the underlying cause of neuropathy based on the history, exam, blood tests, and EMG studies of the nerves. So what is CMT? CMT stands for Charcot-Marie-Tooth. It has nothing to do with your teeth. CMT is named after three doctors, Dr. Charcot, Dr. Marie, and Dr. Tooth, who first described this condition back in the 1800s to describe a group of similarly presenting neuropathies seen in families. This is the typical way that a CMT patient presents to us in clinic. By history, they often report being clumsy as a child. Sometimes there's a history of toe walking or of being a late walker. On exam, patients often have high foot arches called pes cavus. Rarely we see flat foot arches, which are called pes planus. There is a length-dependent pattern to the neuropathy, which means that the longest nerves are affected first. Therefore, the feet and the hand are most affected. Patients often have a foot drop, meaning they cannot lift the foot to clear off the ground and often trip while walking. This causes them to develop what's known as a steppage or stork-like gait, where they have to raise their knees and hips to clear the ground safely when they're not wearing braces. We also use the EMG and nerve conduction studies to determine if the patient has a neuropathy, and demyelinating neuropathies are slightly more common than axonal neuropathies in CMT. What causes CMT? Changes or mutations in a person's genetic material or DNA that code for the proteins in the nerve fibers cause CMT. This can be due to a brand new mutation. 1 in 2,500 live births can spontaneously develop a new mutation for CMT. Or this can be inherited from one or both parents. The first genetic mutation causing CMT1A was identified not too long ago in 1991. Duplication in chromosome 17 of the PMP22 gene. This slide shows the first identified mutation in chromosome 17, the duplication of the PMP22 genes, resulting in 3 copies, causes CMT1A. Now, there are over 300 mutations in over 80 genes and counting that result in CMT. Rarely do patients come to us knowing exactly what mutation they have. So how do we know which genetic test to order? Well, the first step is the clinical history and exam, where we try to identify where the problem is, in the brain, the spinal cord, the nerves, or the muscle. We are looking for signs and symptoms that are suggestive of neuropathy. If we suspect a neuropathy, we do an EMG nerve conduction study to look for axonal versus demyelinating neuropathy. In general, compared to normal responses, axonal neuropathies, where you may recall there are less cables carrying the signal, the size of responses tend to be smaller. In demyelinating neuropathies, where the insulation is leaky, the speed of the responses is very slow. Based on the inheritance pattern, which we get from the history, the speed of the responses, which we see on the nerve conduction studies, and our exam, we narrow down the possibilities and then order a single or very focused panel of tests for the most likely genetic mutation in any given patient. Let's talk about treating neuropathies. In diabetes, strict control of blood sugar can help heal the nerve damage, although it can't be cured. In inflammatory neuropathies, immune modulating treatments can help modify the disease course, though again, it's not cured. In CMT, we have no modifying and no curative treatments to date. This is where CMT research comes in. This slide is courtesy of the CMT Association and shows where we are at with developing treatments for CMT, specifically CMT1A, 1B, 1X, 2A, 2E, and 4, ranging from developing laboratory models to clinical trials. As you can see, CMT1A, which is the most common type of CMT, is the closest to clinical trials, but the others are not far behind. This brings us to our CMT clinic at the University of Michigan Health System. We treat children and adults. We assist in the initial genetic diagnosis, but also follow all our patients annually and help manage the long-term disease course, monitoring, bracing, and rehabilitation. Our goal is to improve the functional outcomes of patients with CMT and promote research towards a cure. We are actively involved in research. However, participation in research is voluntary and refusal will not affect care. Improving patient-centered outcomes such as pain and overall quality of life is our particular research focus. We are part of the Inherited Neuropathy Consortium led by Dr. Mike Shy at Iowa and the Rare Disease Clinical Research Network. For our efforts, the Charcot-Marie-Tooth Association, CMTA, has recognized us as a clinical and research center of excellence. Conclusion. Inherited neuropathy, or CMT, is an umbrella term for genetic mutations that result in peripheral nerve damage. The combination of history, exam, and electrophysiology is used to make the diagnosis of CMT. The management of CMT for now is rehabilitation and braces and therapy, but we are actively researching ways to stop the progression and someday reverse the course of the disease. Thank you, and if you have CMT, we hope to see you someday in our clinic.